Hello and welcome back to the Neurotransmitters. Thank you for joining us today. So, not our first episode on headache, but I think a very interesting spin on headache. I'm very happy to be joined by Dr. Sam Kelokates, a doctor of physical therapy, and thank you so much for joining us today.
Yeah, thank you, Michael, for inviting me on today to talk a little bit about headache with physical therapy.
So, so I'm a DO by training, so I have a little bit of musculoskeletal knowledge, just enough. I'm a few years away from it at this point, working in my specialty, but I kind of came from like a family of chiropractors, and that was always kind of near and dear to my
Hmm.
heart. My father, my sister, some cousins. So, and I was initially thinking of going into like physical medicine and rehab, and so I was fortunate enough as a student to spend some time with physical therapists who some of them had some unique emphases in their practice, and that's essentially what you do. You have a very unique emphasis in your practice, focusing on headaches. So, just tell us a little bit about kind of your journey into that particular niche within physical therapy.
Yeah, so I started my own private practice about 3 years ago in 2021. And I just was kind of doing that on the side on top of my full-time job just to make a little extra income. And so I was going to see some family and friends and just like other people that kind of like came and fell into being seen for, I guess, general orthopedic issues. And I started seeing some friends that had headache, that were complaining of headache. And at that time, I was thinking like, oh, neck pain, headache, it's cervicogenic headache. But as I really wanted to familiarize myself with like how treatments go for that. I really started to find out like neck pain doesn't mean cervicogenic headache, and I got down this whole rabbit hole of like migraine and tension headache and what the pathophysiology was that, and how we kind of there's not, at least in the United States, there's not a really big robust physical therapy program to treat people with headache disorders and really manage them appropriately. So that's where I started really niching down and following that as like where my practice is going to really focus on treating those with headache disorders.
Interesting. Now, as you said, right, everyone thinks, oh, physical therapy, musculoskeletal, but you're also talking about kind of these more primary headache disorders like migraine and things like that. So, you know,
Hmm.
it's very easy for many of us in medicine to kind of fall into this algorithmic approach to different problems. But how do you find that you're able to tailor your approach to these different types of headache?
Yeah. So with the exam, I'm really looking for impairments that are associated with certain types of headaches. So for migraine, it might be certain types of mobility restrictions or pain pressure sensitivity. So like how much pressure they can take in the uh, upper cervical spine or the face that would indicate maybe they have a lower pain threshold. Because there's different interventions we can do that are they're more long-term management, like exercise helps improve pain pressure thresholds. So looking at that, identifying range of motion deficits that might be contributing to their at least for migraine, their migraine trigger, so that their upper cervical spine or their head and face might be contributing as a musculoskeletal trigger for those people. So we're trying to manage that trigger as much as possible, and hopefully at the end goal is decrease the frequency and the intensity of those headaches related to that specific musculoskeletal trigger. And then it goes into the treatment for like lifestyle management. How do we appropriately prescribe exercise for people with migraine since they might have a sensitivity to that increased physical stressor, that increased blood pressure, heart rate? Then we really think about, okay, well, the exercise causes acute dehydration as well as use of blood sugar. So they might become like, like acutely hypoglycemic, even though they're not having any symptoms of that. Their body might respond to that and be more sensitive to an attack at that time.
Gotcha. Yeah, this very, very kind of whole body approach, a whole person approach, if you will.
Yeah.
So that's always a good thing to think about. And I know certainly, we always forget, right? Migraine is not just headache. There's all these things in between, like the fatigue or the kind
Hmm.
of the prodromal symptoms, where like these hypersensitivity things creep in.
Yeah.
Um, and how do you find? You mentioned kind of these sensitivities in different parts of the head and neck and all
Hmm.
those sorts of things. How does that, like, say you do have someone with migraines with these hypersensitive areas? How does that factor into kind of your treatment approach or your selection of different treatment modalities?
Um, the treatments I'm usually addressing with people are ones that tend to help those specific impairments that we find musculoskeletal wise, but then we really need to tailor it down to how does that person respond to that particular treatment. So it's a little bit of trial and error, but also patient preference. If they've gone to like a chiropractor before, another physical therapist, and they were having manipulations done and they always had a migraine attack or they felt worse or better afterwards, that might be an indicator that that's a treatment path that I want to go down or avoid and come back to later, depending on how that person was responding at that time. Also knowing, how do they respond after each treatment session, talking about, did they have a headache attack? Did they feel better? Did they feel worse? Was something better, but something else was worse? And trying to figure out what that means in relationship to their specific unique presentation.
Gotcha. Now, I know before we started recording, you also said there's not a lot of training programs
Yeah.
in the physical therapy world specifically for this. So, how did you integrate kind of the training you did receive in your traditional pathway? And then what kind of education did you seek out, or how did you kind of develop some of your approaches to these patients?
So, like I said earlier, I was really just went down a rabbit hole. So I was reading a lot of research studies about like physical therapy for headache management, which there wasn't a whole lot. There's a growing body of evidence. It's getting more and more in the last few years with more professionals really doing that kind of research. But that's where I started, and then I would reach out to some people, some of those authors about more information, and they would send along some articles or book recommendations. There was one course in the US that came out, but it's a self-directed course, so you just kind of go through and read the content. But prior to that, I read most of the articles that they had cited for that CEU course. So I kind of felt like I was already where I should be after that course. But that's really where I'm at now, is that to really stay on top of managing people with headache is that I need to keep reading literature, talking to neurologists, finding other sources of education, because for physical therapists, we just don't really get a big, robust education in headache medicine or headache treatments, or even the diagnosis about them and how to recognize them in PT school. I remember looking back at one of like the biggest textbooks I have, and it was just called, I think it was just called physical rehabilitation. And there's just like one section that's like, I don't know, a paragraph that talks about what migraine is. And it really didn't even get into the classification on how you actually diagnose that appropriately.
Oh, wow. So, in your experience, what kind of modalities do you tend to utilize most often in your practice? I know there's no one size fits all, but just curious.
I don't really use modalities too often in practice. I do talk with patients about it, like hot, using heat versus cold, and what I kind of think about that, and how ice can help with some people during an acute phase of an attack. The one modality that I do use would be neuromodulation, so like a TENS unit. Think like how like there's the migraine specific devices now, like Cephaly or Nerivio. But what I would use in practice, because I can't prescribe those because I that's not something we do in the US, is a TENS unit. We can recommend them and train people on how to use them for home management uses. Another reason I like TENS units is because they can be applied anywhere in the body. So the head, the face, the neck, the lower back, the mid back. So if they're having pain elsewhere and they're trying to avoid using other medications for pain management, because I know for a lot of people with chronic migraine, there is concerns for medication overuse.
Mm-hmm.
So if I can train them on how to use a TENS for their headache condition, but as well as their other maybe musculoskeletal conditions, then that's a really good way to help manage long term.
Gotcha. And what kind of exercises do you typically end up using, or like actual physical therapies, I should say?
So I would break down treatments into like manual therapies and then into exercise. And then exercise would be further broken down into generalized exercise. So that would be like aerobic training or just generalized strength training. It could even be yoga, swimming, walking, gardening, just being physically active, because that is really helpful for a lot of reasons with overall brain health and wellness. And then we can break it down even further into more headache specific exercise, and those exercises are going to be more tailored to that person's individual impairments. The most common impairments I typically see in the clinic are weakness of the deep cervical flexors, tightness of the suboccipitals, the upper traps, the levator scap, and some joint restrictions. So then we're doing exercises that would help facilitate mobility and stability. So usually exercises of the neck and the upper shoulders.
So it sounds like a lot of computer desk neck type stuff. Probably a component to that as well.
It could be. I sometimes I feel like posture is a little bit of a red herring for people, and
Okay.
it's not that being in being in a bad posture is I don't think that's bad. I think being in one posture for a prolonged period of time is what's bad. Really, our bodies want to get up and they want to move. And when we start getting that achiness or that tightness, it's our body telling us that we're getting fatigued and we need to start moving. So I really, one of the aspects of therapy that I do is actually educating people that like we need to have maybe more movement snacks involved in a day, especially for people that are like work from home or on the computer or at a desk job. Like every hour you should be getting up, whether it's to go for a walk to get water or doing neck specific exercise or doing some like chair yoga. Do something that breaks up that monotony of sitting in one position. Even if it's that forward head posture or a perfect sitting up posture. If I'm sitting in that posture for 1, 2, 3 hours, I'm going to start getting kind of achy and not feeling as comfortable. It's just our body's way of saying we need to start moving.
That makes sense. Now, you mentioned manual therapy earlier. So for those who may not be overly familiar, what's involved in that?
Manual therapy is just the application of hands-on techniques. I would break down manual therapies then into two segments, into soft tissue and then into joint-based interventions. So joint-based interventions might be mobilizations and manipulations of the upper cervical spine, the lower cervical spine, or the upper thoracic areas. Soft tissues would be involved more like the muscles and tendons and ligaments.
Okay. And is that, if you would care to, for those again who might be listening, differentiating like the way, because I know there's differences in application, but also in philosophy
Mm-hmm.
between the way that like physical therapists versus like osteopathic physicians versus chiropractors versus massotherapists. Uh, I know that might be a little too into the weeds, but just broad strokes. Um, how do you think that the way that a physical therapist applies manual therapy kind of differs from these other practitioners?
Um, I can't really speak broadly because there's a few schools of thought for it, but the way I go about
Fair enough.
looking at manual therapy application is, will it help and is there evidence to support its application for a specific impairment that I'm trying to treat? So one of the most common ones I'm using right now is called a manual pressure technique. That specifically is a manual pressure that's applied to the upper cervical spine that's kind of acting as a mechanical trigger for your familiar headache. So the theory for that working is that I'm applying a manual pressure to the upper cervical spine. Those upper cervical afferents are sending neural information back to the trigeminal cervical nucleus. And because of convergence theory, we know that we think that there's a referral pattern from the trigeminal cervical nucleus out through the trigeminal nerve. And that's where people are getting that head and face pain through migraine and tension headache. So if I'm able to stimulate mechanically the upper cervical spine and then mimic or have them feel or elicit their familiar headache, that there might be an application for addressing the upper cervical spine in their headache disorder. Other ways to look at it is if I know that there's patterns for cervicogenic headache based on some other research, if I'm doing certain joint mobilizations to help facilitate that, if I know that there's like imaging that would suggest cervical pathology that would be related to headache, then we could address that through manual therapy as well. But I usually take what the physical exam shows and apply manual therapies as I think that would help those impairments, but also based on what the patient preference is. Because some patients don't want to be touched or they're very apprehensive about it. So that might be something where we get
Mm-hmm.
into later and we see how it goes or we do a trial of it. It's kind of a mixed bag sometimes with some people.
No, that makes complete sense. So obviously, most of these people are kind of dealing with these chronic headaches, chronic neck pain.
Hmm.
I always talk to people and I say, like, this isn't a problem that started overnight. We're probably not going to be seeing an overnight cure.
Yeah.
How do you counsel people and how do you gauge whether your interventions are having a noticeable benefit?
Yeah. Um, so the first thing in eval, actually sometimes even before the evaluation, I talk about are they recording a headache diary? If they are, please bring it in so we can review that. If not, we need to start even before you come in so we can see what the interventions are doing to you. Are they making you worse? Are they making you better? Are they making you worse right afterwards, but then better in between sessions? So we can get a better gauge on what the relationship is between physical therapy and their headache disorder. And then usually for therapy, I'm doing anywhere from 4 to 10 sessions with people. Um, it's very usually I'm not doing less than 4 and I'm not doing that often more than 10. Because at that point, I should be able to do the manual therapy or exercise I need to and teach the person what they can do at home with what we're doing in the clinic. And then we do check-ins from there on out on, do you need to come back in because you're struggling to control things on your own? Are you continuing to make progress with your lifestyle and home exercise program? Um, and we'll track it from there. Did that answer that question?
Yeah, yeah, no, that absolutely does. I know I've had folks in the past, and you always wonder because they'll tell you like, "Oh, I went to physical therapy for my low back pain, or my difficulty walking for whatever reason," and it's like, "Oh, it just made it worse."
Mm-hmm.
And you always wonder, like, well, was it worse, like you said, just after the treatment session? Because certainly, exertion can worsen some of those symptoms transiently, or was it a question of like the therapy plan not matching up with the patient's specific needs?
Yeah. You're asking how do I monitor that?
Yeah.
Yeah. So we're going back. We're looking at what did I do the last session? What do I expect the outcomes to be? Especially early on, if they're very sensitive, they have low pressure thresholds. And I try to be mindful of not doing too much too soon with people, so I avoid having headaches early on. But if we're doing some manual interventions, there's always that risk that we're going to stimulate the trigeminal cervical nucleus, and that could precipitate an attack. Now, we also need to look at, did we do the therapy session early in the day, late in the day? Did you get a good night's sleep afterwards as well? Because poor recovery might lead into an attack as well if you're not able to come back down and reduce your daily stressors and kind of like recharge that battery. But we kind of go through application. If something where I'm doing a therapy and you immediately start having an attack, I would probably link that much closer in relationship to what we actually did. The further we get out from it, the less likely I would assume that it's due to the intervention.
Gotcha. No, that makes complete sense. As far as common mistakes, or let's just say missteps, if we want to be a little softer in our language, that either the person undergoing therapy or the therapist
Mhm.
may make when kind of approaching these patients, what are things that you commonly see like in your referral population?
Yeah. I think one of the common mistakes people make is associating neck pain during migraine is cervicogenic headache,
Mhm.
where you really have to look at what are the other symptoms around that headache condition. Where if it's just headache, you're probably more likely to be just cervicogenic. And with those patients, you can be a little bit more aggressive with the exercises and the manual therapy you're applying just because of the pathophysiology. But if they're having neck pain and migraine, we need to be more mindful of what's the pathophysiology about that, because they're more likely to be more sensitive to those interventions and not tolerate a very hands-on application of therapy to start therapy to start a plan of care. So I think that's one of the big problems I see is misinterpreting what the relevance of neck pain is and what's causing that neck pain. Because for people with migraine, neck pain doesn't mean that they're having a neck problem, because migraine itself can refer pain to the neck and there'd be no dysfunction. There might be some dysfunctions, but that could be also caused because of the migraine, because they're guarding. So we might see mobility restrictions. So we really need to evaluate people during their interictal phases, between migraine attacks to see, do you actually have these neck impairments outside of attack ranges, and then correlating them with how frequently they're having it. Is it related to their attack or not?
No, that makes a lot of sense actually. And that kind of makes me think of a scenario, if you will,
Mm-hmm.
that probably isn't unfamiliar to you. Someone maybe has a pre-existing diagnosis of migraine,
Mm-hmm.
and then maybe they have like a fall or kind of a fender bender with a little whiplash, and then their migraines increase in frequency, and then you also have this superimposed new issue.
Yeah.
How do you tease that apart?
Um, I would just go back more towards the physical exam and what the impairments are. After it, so I do see some patients actually right now that have kind of that similar presentation where they've had a history of migraine. It wasn't really frequent. They're probably averaging less than 4 a month, maybe even less, maybe one every few months. But then they had this post-traumatic injury, whether it's a headache or like a concussion or a whiplash injury, and now their symptoms are coming up and they're becoming more episodic, even into chronic. That would be an indicator to me that their upper cervical spine is involved in that, um, at some level, and we need to start working on desensitizing that area, possibly improving musculoskeletal endurance of the deep cervical flexors, working on proprioceptive control, seeing and really looking at what the symptoms are, correlating to that, what the impairment probably is, and then making a plan of care that addresses those impairments.
Excellent. Now, I know something that frequently travels along with chronic pain is there's sometimes some affective symptoms like depression, anxiety,
Mm-hmm.
things of that nature, like generalized fatigue. Do you find that you're often working with patients who have like some undiagnosed or untreated depression? And uh, do you ever have to broach that in your practice, just out of curiosity?
Sometimes it's I think for when I get to people, they're already working with somebody for that, and they're recognizing that that's an issue for their condition.
Mm-hmm.
Um, But when I do see people that are like, hey, I think that anxiety might be contributing to this, or your depression, or some other issue that is outside of my scope of practice, I'm being sure to want to at least educate on why I think that, and then making a referral to a professional that I think would be best suited to them. The only area where I think I can help people with anxiety is if it's related around exercise. So I want to get exercising, or like I can't play with my kids, and I get anxious about doing it because it's going to trigger an attack. Okay, well, let's build a rehab program around how do we become more physically active. So that's something I feel I can address in clinic and then is appropriate. But if they're really having like an anxiety disorder or depressive disorder, then I need to be making that referral to either a physician or another mental health specialist that can help them with that.
Excellent. Yeah, yeah. There's so much that goes along with headaches and migraines. What do you think, in your like patients who are sent to you, unmet needs in the community, in the migraine and headache community at large?
Mm-hmm.
Where do you kind of see the future of this particular subspecialty going?
Yeah, I think one thing that could benefit a lot of people with migraine and tension headache is having more professionals that are able to properly apply and prescribe exercise. We know that exercise, as far as the long term management tool, is really can be really helpful for a lot of people, especially if we get people before they become chronic. It tends to be more effective in the early in the episodic stage. So getting them more physically active, teaching them how to properly exercise for their condition, and how to monitor, and giving them a framework to work within, where if they're having certain symptoms, is that symptom telling you not to exercise that day? Exercise a little bit. Is that a symptom where it's not going to be affecting your exercise program or physical activity levels? I think having a professional that knows how to look at each individual, prescribe exercise to what we would know would be an appropriate level, but then making it very individualized and unique for that person to help them manage their condition is a need that I think would help a lot of people with a headache disorder, um, in the long run.
Excellent. And I kind of thought of another question as you were talking. One of the things that back to concussions and things like that you mentioned is that we'll sometimes see kind of these vestibular disorders creeping in.
Mm-hmm.
How much of vestibular therapy do you find yourself kind of working on alongside of kind of migraine specific treatments?
Yeah. I've been more in the last 3 years of my practice, very little vestibular dysfunction. It's just the patients that have come to me. Usually, if I'm finding something that has more significant vestibular dysfunction, now I'm referring to a vestibular therapist. I just don't have enough training to deal with like very specific vestibular needs. I For some people that do come in that have some types of dizziness, if it's mild and one of their lesser symptoms, that's usually something that the treatments that I'm going to work on, as far as neck specific exercise and manual therapy related to the neck and proprioceptive exercise, will help decrease those vestibular symptoms. But if I think they have another vestibular disorder on top of a headache disorder, then I'm referring to another therapist.
Gotcha. That makes sense. Yeah. Very, those, I can only imagine how challenging those patients would be.
Yeah, so I do see sometimes some patients where they're seeing a vestibular therapist and they're seeing myself, and it's not that I can't do vestibular rehab. I just don't have the education yet to be able to do advanced levels of vestibular care, and I'd rather give them a therapist that is better suited to them.
Oh, that makes complete sense. I often find myself referring to subspecialists in my own field as well when it's just like, this is something a little strange. You probably need a second opinion.
Yeah, it's like I recognize the problem here, and it's just outside of my expertise, and I want to get you that expert.
Absolutely. So, any final thoughts? What that you think like the general public should be looking into, even if they haven't seen a PT yet, or obviously make sure touching base with a professional before starting any exercise regimens. What would
Yeah.
your general recommendations be for the people out there?
My general recommendation would be so even for people that have seen a physical therapist and it didn't go very well, it's that don't not consider physical therapy again. There's so many therapists out there, and we have different training from across the United States based on our manual therapy education because there's so many different schools of training. Same thing with our application of exercise and our background with exercise that keep trying to find that right professional and ask maybe more specific questions when you're kind of doing your own interview for your health professional. That do they know what migraine is? Do they know how to make that diagnosis, or at least the diagnosis criteria for that? Because if they don't, they probably don't know some of the nuances of the condition and how physical therapy will really affect them down the line.
And that actually is a great point, and that's one of the I think even me as a healthcare professional, right? When I'm referring people to physical therapy, I work in a healthcare system, and it just goes into the ether, if you will, right?
Mm-hmm.
It goes to the therapy department, and I know some of the therapists, but they're mostly the inpatient therapists that I work with on a regular basis, right? So they're working with gait and orthopedic injuries and things like that. Where is if I'm referring to like say a vestibular therapist or someone with headaches specifically,
Yeah.
I don't necessarily know who they're going to. Uh, do you have any good recommendations, or is this more a question of like you got to get out there and kind of beat the pavement and meet people, find out what their areas of expertise are?
Yeah, that would probably be the best course. Is you kind of have to ask. You'd probably be better off with a therapist that understands manual therapy. Um, Another good resource would be somebody that does vestibular therapy. They're going to at least have a good understanding from a vestibular migraine perspective on migraine disorder,
Mm-hmm.
and be a little bit more understanding of how exercise or manual therapy might affect it. Now, they might not have the manual therapy skills in as a because really most vestibular therapists tend to align more on like the neurological side of physical therapy. So they're doing less manual type therapies. Though there is a and those people that the therapists that do manual therapies tend to be orthopedic in nature.
Mm-hmm.
So having somebody that understands either side of the manual therapy side or the vestibular side could probably be a good therapist for you. I would just make sure that they understand that there's going to be a lot of trial and error with how you respond to therapy interventions, and we don't really want to make assumptions that you're going to be too sensitive or you'll be fine as with this intervention. We need to really tailor it to you, ask you what you've done before, what you're sensitive to now, and then work with you continuously throughout the plan of care.
No, that makes sense, right? Got to tailor it to the individual.
Yeah.
So thank you so much for coming on, talking to us a little bit about physical therapy for headaches and migraines. If people want to find, I know you've been putting out some good stuff online. Where can they find you online?
I tend to do a lot right now on Instagram um, and LinkedIn and Twitter, as well as my website. I try to post blogs pretty often to really, though the blog is more patient facing than it is clinician facing. But on the other platforms, I do a little bit mix of patient and provider facing information.
Excellent. And if people are looking for a physical therapist, what city are you located in again?
I'm located in Philadelphia, PA.
Awesome. Awesome. Well, thank you so much. You can also find me online at Twitter/X at Dr. Kentris, DrKentris, and our website, theneurotransmitters.com. Thank you, everyone, for tuning in, and we'll see you all again next time.